Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 355 of our pharmacotherapy series, which majors in asthma. The next case reads, ABC is a 3-year-old, 16-kilogram boy with a 1.5-year history of recurrent wheezing 3 days per week and nocturnal awakenings 4 times per month. His medications include albuterol syrup, 2 mg, 5 ml, 1 teaspoonful 3 times a day, and albuterol metered dose aerosol inhalation 4 times daily as needed for wheezing. ABC demonstrates the use of the inhaler with his mother's assistance. The mother holds the inhaler in ABC's mouth and actuates it at the end of a deep inhalation. ABC's mother tells the clinician that he appears jittery after taking albuterol syrup. So my question to you is, what is the first step in deciding how to improve ABC's long-term drug therapy? While keeping in mind the goals of therapy defined by the NIH guidelines, that is the EPR3, the first step here is to classify ABC's asthma severity for infants to age 4 years. Because ABC has symptoms 3 days per week and 4 nights per month, he should be classified as moderate persistent. Note that the presence of even one of the features of severity places the patient in that category. The next question reads, what would be a reasonable initial regimen for ABC? Because ABC's asthma is classified as moderate persistent, the clinician is now in a position to select appropriate long-term therapy. Using EPR3 for very young children, low or medium dose inhaled corticosteroids, abbreviated as ICS, with an as-needed short-acting inhaled beta-2 agonist would be the choice for ABC in considering this decision, EPR3. For example, it is noted that step 2, low-dose inhaled corticosteroid, is preferred in this very young age group based on the strongest evidence, that is evidence A. It is further noted that other recommendations are based on expert opinion and extrapolation from studies in older pediatric patients. EPR3 suggests an initial trial of low-dose inhaled corticosteroid in very young children who have not previously been treated with inhaled corticosteroid. ABC could receive low-dose inhaled corticosteroid treatments via nebulizer, budesonide, or metered dose inhaler plus a spacer. Most children aged 3 years or younger cannot use dry powder inhalers because of inability to generate sufficient peak inspiratory flow, abbreviated as PIF. Because ABC matures, he may be able to use some dry powder inhalers, e.g., discus. Because oral beta-2 agonists are not recommended by EPR3 and the albuterol syrup was not well tolerated, they should not be used. If concurrent inhaled albuterol is administered correctly, oral albuterol is not needed and would only be expected to add adverse effects. ABC's mother must be educated about asthma, its treatment, and the appropriate use of medications, e.g., proper use of inhaler devices. It is anticipated that because of his young age, ABC will find it difficult to use a metered dose inhaler. So my question to you reads, what alternative inhalation devices are reasonable? Children younger than 5 years of age generally have a difficult time coordinating the use of standard metered dose inhalers. Therefore, the inhaled corticosteroid and short-acting inhaled beta-2 agonist should be administered by another mode of delivery. For example, the as-needed beta-2 agonist and scheduled inhaled corticosteroid could be administered with an inhalational aid, spacer, or valved holding chamber, which is connected to a metered dose inhaler. A nebulized corticosteroid preparation, that is budesonide, is available for very young children. Inhalation aids significantly improve the efficacy of medications that are administered by metered dose inhaler in very young children or other patients who are unable to coordinate the plain inhalers correctly. The aero chamber is a widely used valved holding chamber. The medication stays in the chamber for a few seconds until the patient inhales slowly and the inhalation valve opens. Studies have shown that many children as young as 2 and 3 years of age can use metered dose inhalers with spacer devices by modeling after a parent. Spacer devices with face masks are required for some young children. Extender device-assisted delivery of aerosolized medications is as effective as nebulization in the home management of chronic severe asthma and even in the accident and emergency department treatment of asthma in children. Aero chamber is an example of a device that contains a flow indicator whistle that sounds if the patient inhales rapidly. This whistle is particularly effective in teaching the patient the appropriate slow inhalation technique. As a 3-year-old, ABC may not need a spacer with a face mask, but the clinician should verify correct use of the device by observation of the patient's or caregiver's administration technique. Alternatively, the inhaled corticosteroid could be administered to selected children by using a breath-activated dry powder inhaler, e.g., budesonide, marketed as Pulmicort Flexhaler, or fluticasone, combined with salmeterol in Advair Discus. In young children, the Discus has the advantage of requiring a lower peak inspiratory flow than Flexhaler, and it has been used successfully in children as young as 4 years of age. Another option is the Twistala used for delivery of mometasone, marketed as Asthma-NCLEX, but it is approved for children 4 years of age and older. Many pediatricians may choose a nebulizer to administer short-acting inhaled beta-2 agonists to a 3-year-old child. This method is certainly acceptable and very common, but it takes longer to administer the medication, that is about 15 minutes, and the device must be properly cleaned and maintained. Because ABC recently turned 3 years old, therapy should be initiated with nebulized budesonide, Pulmicort Respules, in a low dose of 0.25 mg twice daily. As mentioned previously, EPR3 suggests an initial trial of low-dose inhaled corticosteroid in very young children who have not previously been treated with inhaled corticosteroid. The plan is to switch ABC to a dry powder inhaler or metered dose inhaler spacer in 12 months, as soon as he and his caregiver can demonstrate correct use. ABC's clinician should assess the response to low-dose budesonide in 4 weeks. Therapy can be stepped up if necessary and subsequently stepped down in the coming months, if possible, so that optimal asthma control is achieved at the lowest inhaled corticosteroid dose possible. ABC's parents are wary of their son taking corticosteroids on a continual basis after having read about serious side effects attributed to corticosteroids on the internet. So my question to you reads, how should the parents be counseled? Corticosteroids reach the systemic circulation minimally via inhalation in part because they are largely inactivated through first-pass hepatic metabolism. However, a dose-dependent response is evident, and clinically significant adverse events resulting from systemic exposure can occur, albeit more commonly with doses at the high end of the range. Long-term studies in pediatric patients have examined the effects of inhaled corticosteroid on growth reduction, bone density, and adrenal suppression. Although inhaled corticosteroid can cause a mild and temporary reduction in growth velocity, final height attained in adulthood appears to be within normal limits. Bone density and risk of fractures have not been found in the majority of investigations to be affected by inhaled corticosteroid. Although a measurable reduction in serum and urinary cortisol levels is not an uncommon finding in studies of inhaled corticosteroid, clinically significant adrenal insufficiency solely caused by inhaled corticosteroid is rare, although again it is more likely to occur with high doses. In summary, these adverse effects are generally of minimal clinical significance, with the benefits of well-controlled asthma far outweighing the risks. The most common local side effect with inhaled corticosteroid therapy is oropharyngeal candidiasis, that is thrush, but this problem is rare with any delivery system. With metered dose inhalers, it can be further minimized by use of a spacer device. Rinsing the mouth with water after use of any inhaled corticosteroid is also recommended. Another possible local side effect is hoarseness, also known as dysphonia, and spacers may not effectively reduce this problem. Dry powder devices, e.g., FlexHaler, may have less dysphonia associated with their use, but further study is required to verify this. The next case reads, PCV, a 33-year-old woman, presents to the clinic with a history of asthma and seasonal allergic rhinitis, i.e. hay fever, each spring but not the rest of the year. She describes her asthma as mild and intermittent. Except during springtime, her daytime symptoms occur less than once per week, and she does not have nocturnal symptoms. Each spring, however, these symptoms worsen, and she requires her albuterol inhaler, her only asthma medication, thrice daily or 4 times every day. During springtime, she takes a non-prescription antihistamine, which offers some relief. So my question to you is, how can PCV's management be improved? PCV appears to have intermittent asthma during most of the year, but converts to moderate persistent asthma combined with worsening rhinitis symptoms in the springtime. This syndrome is consistent with a diagnosis of seasonal asthma and allergic rhinitis. Although as needed albuterol is appropriate most of the year for PCV, she needs anti-inflammatory therapy during the spring. Therapy to reduce airway inflammation should begin before the onset of tree and grass pollen season and continue throughout the spring, e.g., 3 months. Per the NIH guidelines, an excellent treatment option for PCV is low-dose inhaled corticosteroid combined with a long-acting inhaled beta-2 agonist, abbreviated as LABA. Monotherapy with medium-dose inhaled corticosteroid would also be an acceptable therapy. Not only are the causes and pathophysiology of allergic rhinitis and allergic asthma similar, poorly controlled rhinitis also serves as a major asthma trigger. In addition, PCV should also ideally receive an intranasal corticosteroid if antihistamines, preferably non-sedating, do not provide optimal relief of her allergic rhinitis. Intranasal corticosteroid therapy not only offers excellent relief of nasal symptoms but also improves asthma control. Good control of rhinitis is helpful in maintaining optimal asthma control. Despite precautions listed in manufacturer literature that older, i.e. sedating, antihistamines should be avoided in asthma, these agents are safe in patients with asthma. Nevertheless, non-sedating antihistamines are preferred. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 356.